Okay, so I think I'll make my brief announcements and then I'll hand the mic over to you, Dr. Musa. How's that sound?
Yes, ma'am.
Okay, great. All right. Thank you everyone for logging in and welcome to Department of Medicine Medical Grand Rounds. We have a wonderful CPC hosted by Hospital Medicine today. Before we get started, just a couple of announcements for those of you who have been logging in to claim CME credit. Sorry for the error in last week and this week's CME code. I think we gave you a 6-digit code when you actually need a 5-digit code. So the 5-digit code for today is 18858. And I will put that back in the chat in just a second. And then the Department of Medicine bulletin will have the correct code when that email is circulated later on this afternoon. Other announcement is that Department of Medicine Grand Rounds is canceled for next Tuesday because it will be Tuesday, November 5th. Please instead make sure to go and vote because that is election day. So that is why we're canceling Grand Rounds on November 5th. And with that, I'm going to hand the mic over to Dr. Musa to get us started.
Thank you. Thank you very much. And looking forward for a great CPC today. The Division of Hospital Medicine hosts the CPC twice per year in the fall and in the spring. And this is our fall. We have a host of presenters with us today, and we are happy to have PGY3 resident who is interested to be presenting the case, in addition to our attending who worked with her, with Dr. Aloy. So I will introduce the team, and I will start by Dr. Saklawi. So Dr. Saklawi, in fact, he recently graduated from internal medicine, Emory Internal Medicine program, and he is a hospitalist at Grady. And he's very passionate about medical education, and he's interested to be a co-lead in the CPC in the upcoming future. So we're looking forward for his way of doing the CPC, hopefully with some new energy. So without further ado, I will pass the baton to Dr. Saklawi to introduce Dr. Aloy, and we'll get the CPC started.
Thank you so much, Dr. Musa. I was walking in the hallway and Lana bumped into me and she told me, I have an amazing case. And I told her, Lana, don't tell me the case. Tell it to me in aliquots and make me guess the diagnosis. So we played that game and it was an amazing case. I suggested we present it today on Grand Rounds. Lana is a third-year internal medicine resident. She's interested in hospital medicine, medical education, and healthcare management. She is the world's #1 fan of Barcelona and Lionel Messi and watches every single game every time. So, Lana, passing the mic to you.
Thank you so much, Yusuf. Everything he says is true. Let's start with a great case. I'm just going to share my screen. Okay, awesome. So this is the case of rapidly developing weakness. Starting off the case, sorry, 1 second. Okay. We have a 54-year-old female with no past medical history. She presented with 1 week of non-pruritic rash and lower extremity weakness. Initially, she started with bilateral hip pain, which then progressed to unsteady gait. On the day of presentation, she was trying to get out of bed and was found on the floor and could not move her legs. 12-point review of systems was performed, and it was positive for 1 day of fever, nausea, vomiting, and diplopia. From a social history standpoint, she works from home in Atlanta. She does have a cat. She has no recent travel or hiking. She has never lived outside of the US. In terms of health-related behaviors, she has no history of homelessness, incarceration, or sex work. She has no sick contacts and no known drug allergies. In terms of home medications, our patient was only on 2. Estradiol 0.1 milligrams, 24 hours, and progesterone 200 milligrams. No other supplements, nothing else. In terms of her physical exam, our patient's temperature was 38.8, Her heart rate was 92. She was normotensive with a blood pressure of 125/67. She was satting 100% on room air. In terms of general appearance, she was lying in bed, did not appear to be in acute distress. From a head and neck exam, she was anictoric, she had moist mucous membranes, and she had no oral ulcers. From a cardiovascular standpoint, she was regular rate and rhythm, S1 and S2 audible. She had warm extremities and no peripheral edema. From a pulmonary standpoint, she was clear to auscultation bilaterally. She had symmetric chest rise. Her abdomen was soft, non-tender, and non-distended. From a skin standpoint, she had blanching or biliform macular rash on her upper extremities, her lower extremities, her chest, abdomen, with scant petechiae sparing the palms and soles, as you can see in the picture. This was covered all over her body, essentially. It was non-itchy. From a neuro standpoint, she had intact mental status and cranial nerves. Her visual fields were intact. Her pupils were equal, round, reactive to light and accommodation. From a strength standpoint, her upper extremities were 5 out of 5. She had significant abdominal weakness, with 4 out of 5 strength in her lower extremities as well. Her reflexes were 2+ throughout, and her proprioception was normal. She did have mildly reduced vibratory sensation in her lower extremities. She was unable to walk due to the weakness. From her labs, she had no white count with a WBC of 6.6. Her hemoglobin was 14.6. Her platelets were 139. From a chem panel, her sodium was 134. Her potassium was 3.6. Her chloride was 101. Bicarb was 24. Creatinine was 7, and creatinine was 0.62, and her BUN was 7. AST was 18. ALT was 12. Alk Phos was 187. ESR was 16, CRP of 1.7, and a CK of 107. So her only abnormal lab was a mildly low platelet count of 139. Workup included a COVID, flu, RSV, which was negative, and blood cultures, which were no growth to date. The patient was started on clindamycin prophylactically. She was persistently febrile to 39 Celsius daily, and she had new onset urinary retention requiring a Foley. Imaging. We obtained a CT head without contrast, which showed no intracranial abnormalities. MRI brain and orbits showed no intracranial or orbital abnormality. We went on to get an MRI cervical, thoracic, lumbar with and without contrast. It showed longitudinally extensive bilateral cord signal abnormality affecting the central gray. There appeared to be more involvement of the anterior horns. Her lower thoracic cord and conus appeared questionably slightly expansile. Dorsal columns were spared, and there was no abnormal enhancement. Recapping the case so far, we have a 54-year-old female with no significant past medical history, presenting with 1 week of fevers, rash, and progressive ascending lower extremity weakness. She was transferred to the neurology intensive care unit for further management. Consults. We consulted neurology to evaluate the rapid ascending weakness, and ID was consulted to assist with any further workup. Advanced labs. Patient underwent an LP. Glucose was 48, which was normal. Protein was elevated at 87. Nucleated cell count was 88, with the differential being 67% lymphocytes and 20% neutrophils. And her CSF was oligoclonal band positive. Further labs that we had ordered, ANA was negative. Her acetylcholine receptor antibody was negative. Rocky Mountain's spotty fever antibody was also negative. Her RPR was non-reactive. Rickettsia antibody was negative. Borrelia antibody was negative. Her urine drug screen was also negative. Extensive autoimmune blood work came up negative, including MOG and NMO antibodies. So recapping the case, this is a 54-year-old female with no past medical history, presenting with 1 week of fever, rash, and progressive ascending lower extremity weakness. Her MRI showed bilateral cord signal abnormality affecting the central gray and mainly anterior horns. She underwent an LP, was found to have lymphocytic pleocytosis and illegal clonal bands. So now I'm going to pass on the mic to Dr. Noel Malik. Dr. Malik is an associate professor in our Division of Hospital Medicine based at Emory University Hospital Midtown. He also serves as an associate program director for the Internal Medicine Residency Program and a small group advisor for the medical students at Emory School of Medicine. After graduating from Vanderbilt, he completed his residency and chief residency at the University of Washington in Seattle. He spends most of his time off embarrassing his 2 daughters and recently became a father of a teenage girl and appreciates any thoughts and prayers going forward. Take it away, Dr. Malik.
Thanks, Lana. I appreciate the opportunity to talk about this. My hope is to kind of go through the aliquots as I received them. I know you've received all the information kind of all at once. And my hope is to use some fidelity through my diagnostic reasoning process and to consider some diagnostic pitfalls in how I go about it. So one way I'll try to prove that is when I got the aliquots, I immediately wrote stuff down. And so this is proof that I wrote stuff down, and I'm basically transcribing what I wrote 2 or 3 weeks ago into my PowerPoint slides. And let's go for it. So I start off with our chief complaint, someone who is healthy and comes in with rash and lower extremity weakness. I've done this a few times with the CPCs, and for some reason, I always seem to get a rash as part of my case. You would think that I would have gotten more agile in dealing with rashes by this time, but sadly, no. In my mind, that is why God created Justin Shealy to help us out with these kind of things. But what I do know is that this was an acute time course, and I think time course and presentation is something that I think about a lot when I think through cases, and it involved, as far as I can tell, skin and some sort of neurological system. So already thinking about a multi-organ system approach. Something I asked I recognize that with expediency, we oftentimes just put pictures in the chart and we can just text our friendly neighborhood dermatologist for a consultation. I do think there's value in thinking about the rash and as I try to do this, and what I would encourage people to do as well, the learners, is to have an idea of what are you looking for when you're asking things. And so I kind of reach back to my brain. It's like, I think there's something different between when you have a diffuse rash versus a localized rash. Is it blanching, meaning is there some sort of vascular component? Similarly with purpura, is it flat or could there be purpura? Where did it start? I actually did not get that initial information beginning, but I'm curious about where it starts, how it progressed, and of course, can we make a heuristic connection about palm and sole? So those are kind of my just general thoughts about the skin rash, even before we get started. With weakness, maybe I have less things to think about. I'm curious how severe it is really. Is it affecting proximal muscles or distal? Thinking, could this be a central process or a peripheral process? Is there a sensory component to just the weakness? And as I mentioned, how severe is it? We've come to find that this is pretty severe, but those are the kind of things that I'd be thinking about initially. So I'm still kind of in that first type 1 thing, I guess, thinking through all those things. So this was what I came with, just the first thing I wrote down as I was thinking about the case. And I put it in buckets like many people do in various things. I thought about neurological things because it seemed like there's weaknesses going on. Could it be a demyelinating process, an acute demyelinating process, or polyneuropathy? Could it be myasthenia gravis per se? Is it something related to the ID bucket? Could this be a perineoplastic syndrome with kind of multi-organ system involvement? With the rash and weakness, could this be TTP? Rheumatologic, I think you could put anything on the rheumatologic. The one that came to mind was, once again, rash and muscle weakness was dermatomyositis. And then maybe some other things, maybe vitamin deficiencies or eosinophilic. So this is my type 1. This is what I put down in the beginning, right when I got started. So the question I think about next is, what do I need to know? How do I start with this, even before I get any more aliquots? I like to know her exposures, of the patient's exposures. what is this person's immune status? I think that impacts definitely the ID component of things. What are their TB risk factors? Are there other systemic symptoms that can point me to other areas to focus on? And drugs, drug allergies, and then for rheumatologic disease, I think about family history a lot. So this idea of like, what are the illness scripts I'm looking for? What are the illness scripts for the various things I listed up there, and how much will this match with what the next aliquots I get? And so this is really slide one, the first sentence. And so I've spent a lot of time just thinking about this before getting any sort of information afterwards, which I think is the fun part of diagnostic reasoning. And so hopefully I'll remain to be vulnerable to you. And so, just to be clear, this is what I did in aliquots of the different slides, and I'm transcribing what I did. Let's start with the next slide I got was meds, and she's on some hormonal therapies, which, didn't seem, unless it was new, I couldn't really see how it was pertinent, but I like to play a game to try to maybe mitigate potential cognitive bias is to ask like the what if or the how. Like what if the meds were related, and how can I make it related? Well, maybe she's hypercoagulable because of hormonal therapy, and maybe she got antiphospholipid antibody syndrome because she has an underlying rheumatologic issue. I'm not sure if that's the case or not, but that's a technique that I would encourage and I try to do to keep an open mind on certain things. The next slide I got, aliquot, was about her exposures, and we're getting a sense that she has no workplace exposures. She has cats, and so you might think about an exposure with cats. We're not getting a report of any risk factors for tuberculosis or an STI, and presumably an immune status situation. And importantly, no travel or hiking history. Thinking about ticks, I had foodborne illnesses, atypical things, or just things that are unusual. So that's helpful to maybe hopefully narrow the differential. I might want to know a little bit more about our sexual history and our lifestyle habits. If this was, meaning alcohol use and other use that might impact proprioception or sensation or even weakness. I think this was an episode of House. We would consider breaking and entering their house and maybe, looking back to see if there's a mole there, or look at their planner and have they been visiting, endemic areas for certain things. I don't encourage breaking and entering. The next aliquot I got was this person has days of fever, 1 day of nausea and vomiting, fever and diplopia. I didn't really make too much of nausea and vomiting because it's such a non-specific finding, and I think she's sick. But the fever is important, I think, and it seemed like the fever occurred after the initial presentation. And then this is when I heard about the diplopia, and so even though not only she has weakness, but now she has another area that might include a neurologic finding in the central nervous system. So my questions from this aliquot was there any confusion? Because I'm like, does she have lethargy? Could this be an encephalitis issue? Because with her neurologic symptoms, I'm getting the sense that it may be more central than peripheral. And either way, at this point, I'm like, this person was going to need an LP and some imaging to help me kind of help clarify some of the information that I received. So next is exam, and what am I interested in the exam before I got the information? I'm of course curious about the neurologic exam. Could there be a meningismus component to it? Her mental status, reflexes, think about Guillain-Barré, and the sensory component. I'd like to know about the rash, although I'll be honest, I'm not sure if I would do too much with that rash information. And then from maybe thinking about autoimmune or rheumatologic, I'd be interested in mucosal surfaces, joints, nail beds, things like that. So the information I got was that she's febrile but not hypotensive. There were no oral ulcers that were reported. She has this petechial-macular, I guess, not purpuric rash that was not involving the palms or soles. For a neurologic exam, the weak abdominal muscles is something I've not seen reported very often, so that seems concerning. Could there be ascending paralysis? Her upper extremity strength seemed to be okay. This is a bilateral complication of her lower extremity, so reflexes are normal, which seems atypical for Guillain-Barré or other diagnoses like that. And her pinprick is intact, but vibratory sensation is decreased. So something's going on with her spinal cord. I didn't know what at the moment, but something's going on. So at this point, I'm going to be revisiting my initial differential diagnosis, which is what you see here, and thinking about, okay, what information do I have? I don't really have a clear exposure history when I'm thinking about like tick-borne or arboviruses, or maybe even things related to unusual, things that you might see on travel or her immune status. Presumably, she's immunocompetent, as far as I can tell. Once again, I'm still kind of locked into the fact this is multi-system. I am concerned about the ascending weakness. Without confusion and encephalopathy, I thought encephalitis was less likely. That really wouldn't have changed my thought that we would need CSF studies to move forward. From an autoimmune rheumatologic syndrome, I thought it felt too acute. So I think the time course didn't quite fit what I was thinking about. Didn't have other surfaces or joints that I might think to be involved. And I thought drug reaction seemed to be pretty unlikely. So at this point, just kind of revisiting where I am right now, it felt like it was going to fall somewhere in like the neurologic ID bucket. All right. So the next several slides that I get, once again, I'm trying to give you some proof this is what I did. I got the fact that she had negative cultures. I didn't find that to be surprising because she didn't really think this was a bacterial process. I thought the fact that she was persistently febrile with high fevers was important. In my mind, I think about viral syndromes, drug fevers, or even malignancy, perineoplastic as being part of that script for me. And so I'll keep that in mind. Her labs, this is one of the things where you see someone who seems to be sick but has normal labs, and that's always like puzzling and concerning, surprisingly unremarkable. Whatever this is not impacting livers or kidneys, at least at this point. With a white count, I'd be curious about a differential diagnosis. Her platelet count was low, but maybe not TTP level low. The CK being low, potentially myositis would be less likely, thinking about the dermatomyositis or other muscle breakdown. The CRP and SR and SED rate never failed to make me angry in terms of like, why is it normal? It shouldn't be normal. It should be elevated. Why is this normal? That doesn't make sense. And once again, this patient seems sicker and maybe more concerning than the labs would suggest. And that makes me concerned. And so what next? I think that we might need room labs, although I'm plus or minus on that. Like I said, did not really feel that was the right bucket. I totally could be wrong. As I mentioned, I do think the LPCSF was really important. I'd like to know her immune status. And she needs imaging, as I mentioned. And so I thought she would need an MRI brain. The spine with her ascending weakness and asymmetry, I thought would be appropriate to get. We found out that MRI brain is normal. Once again, I was a little surprised that the eyes were normal. Could there be a neuritis or optic neuritis component to it? Her MRI spine showed this central great cord signaling affecting the anterior horns and sparing the dorsal columns. This seems like a total step one question where it should like lead to a heuristic connection. Not to me, it didn't. So the one deviation I did was I spent 30 seconds seeing if Google could help me out. And as it turns out, Google says this is an anterior spinal cord syndrome, which was completely inconsequential, unhelpful to me. So I moved on. So my problem presentation at this point was 54-year-old healthy female, no known exposure to travel with an acute onset of this rash and weakness with persistent fevers, diplopia, but no confusion, and this potential ascending paralysis and abnormal spinal imaging concerning for some sort of multi-system process, maybe infectious in nature with the fevers, either leading to a neurological manifestation or there was an inflammatory response that had a neurological effect. At this point, I like to think and stop and say, okay, where am I now? Is this an atypical presentation of a common syndrome? Or is this an uncommon syndrome that I may have not seen, but this is the illness script that I would see if I looked it up? Or is Dr. Louis being really mean to me and giving me an uncommon clinical syndrome and giving me an atypical presentation to this? And the other part I think about is, am I anchored too much on that type 1 thinking, that first differential diagnosis that I put up? Am I anchoring too much? Am I not thinking outside the box from that? Or am I putting too much weight on a positive or negative finding? When things don't fit an illness script, am I putting too much weight on things that I found or things I have not found? And I find that is can be challenging if not fitting, at least in my illness script. So then we get the CSF, which shows a pleocytic lymphocytosis and this oligoclonal band positivity. I think many of us probably think of MS when we think of oligoclonal bands being in the CSF. Once again, I did not really felt the clinical picture. Now, with the pleocytosis, I think it brings its own differential diagnosis, many of which is pretty similar to at least my initial diagnosis thoughts were, could this be infectious or could it be non-infectious, which includes some autoimmune things I did not think about initially, like sarcoid, for example, Behçet's. And so this is kind of where I'm left with. We get a little bit of information showing that, our ANA, the RPI, some of the tick stuff was negative. Some of the autoimmune encephalitis stuff was negative. So what has left me with at this point is like, okay, I have a lymphocytic pleocytosis and this neurologic manifestations. Could this be a viral syndrome? I don't have an exposure history to kind of help me with that. I think we probably need more CSF studies to maybe check for some unusual or maybe usual type of organisms. I was curious, and other people looked at like, okay, well, if this is a viral syndrome that leads to neurologic weakness, once again, in my experience, this seems to have not all the findings that I'm used to. Like I'm used to seeing when you have arboviruses to have things like encephalitis and other types of neurologic syndromes. We obviously don't have a lot of exposures here. I'll say this summer at Midtown, we've had a number of patients who've come in with West Nile, so we know it's a real thing. It happens. So it's not an uncommon syndrome. Maybe this is an atypical presentation of a syndrome that I have seen before. But thanks to me, we have, I go back and like, where am I now? And I'll stick with that for right now. I'm glad we have smarter people to help me do this. When I need assistance, the thing I'll ask and kind of remind myself and maybe encourage everyone is when you're calling your consults is to maybe they can help reconcile when there's variations in clinical presentations and classic illness scripts. Obviously, my colleagues and consultants have a more breadth of experience of seeing variations in how patients present. And for my own learning, are there pathognomonic findings that I have missed that I did not know? Are there heuristic connections that I should have made, to help me, to guide me along? And I think that is it. And I will then pass it along to hopefully someone to give us some more information.
That would be me. All right, I'm just going to share real quick my last two slides. And I promise I wasn't trying to be mean to you, Dr. Malik. So a break in the case. Our patient CSF was positive for West Nile virus antibody IgM. So a recap of the case, a 54-year-old female presenting with fevers, rash, and lower extremity weakness, found to have bilateral anterior spinal cord abnormality, extending the length of her spine. A lymphocytic pleocytosis ultimately diagnosed with West Nile virus. She was then discharged to acute rehab with a Foley for her continued urinary retention, with outpatient urology follow-up as well as outpatient neurology follow-up. And now I'm going to transfer the case over to Dr. Daniel Gromer. Dr. Daniel is an assistant professor of medicine in the Division of Infectious Disease at Emory University School of Medicine. He attended college and medical school at the University of Pennsylvania, internal medicine residency at the Mass Gen Hospital, and infectious disease fellowship at Emory University. Dr. Gromer is an investigator at the Hope Clinic of the Emory Vaccine Center and attending physician at the Emory University Hospital Midtown. Murray does a mixture of inpatient and outpatient clinical care. His primary research interests are in vaccine responses, clinical trials, immunology, and immunocompromised hosts. And his outpatient clinical focuses are on HIV primary care and oncology ID. I'm going to pass it on to you, Dr. Gromer.
Hey, thanks for the introduction. I'm just going to share my slides and make sure you guys can see that. And how's that? Is that okay? More importantly, I didn't include anything about my family in the bio, but you're gonna see my daughter in one of the slides, so I think it's okay. Noble Malik, that was a tour de force, which makes this a whole lot easier. Actually, for me, I saw the patient in the hospital and swung and missed on this. So this is my second crack at it. This is going to be a talk on acute myelitis and West Nile virus from the infectious diseases perspective. I have no relevant disclosures, and here's the roadmap. It's just those two topics, which are way too broad to like get all in in a single 10-minute span anyway. But I wanted to briefly touch on a couple of overlapping sort of definitions that I think come into tension sometimes and came into tension in this case. So there are a lot of sort of confusing definitions in this sort of world of like inflammatory spinal cord dysfunction, brain dysfunction sort of universe. But the two that I want to talk about are transverse myelitis and acute flaccid myelitis. So transverse myelitis is any inflammatory myelopathy event in the loosest definition, all the way to the strictest definition of inflammation across a complete transverse section of the spinal cord. And acute flaccid myelitis is inflammation of the anterior spinal motor neurons in the gray matter, leading to paralysis. Previously called poliomyelitis, it was on one of Noble's slides, and it sort of means at the exclusion of the dorsal part of the spinal column. And it can come into tension with particularly the looser definition of transverse myelitis. Here is a fully fleshed out or mostly fleshed out up-to-date differential diagnosis for infection-related transverse myelitis with the loose definition. And I find this really overwhelming and impossible to digest. And this is the value of coming to a diagnosis of acute flaccid myelitis, which is really hard to do, but it super narrows your differential to a handful of viruses, at least when you're talking about infectious causes. The problem is when you're like first seeing a patient and getting these little aliquots of data, you can't like just immediately say they have acute flaccid myelitis. You're often more stuck with they have some sort of inflammation and spinal cord dysfunction. And so I wanted to talk briefly about a personal approach to distilling some of this table down into something more digestible, which Noble has already largely done. So I copied this all over into a couple of slides. These are viral causes, and these are everything else causes from an infection standpoint. And here's where I'd like to take a pit stop to say the initial goals of an ID consult and often of an admission in this sort of situation, fever, spinal cord dysfunction, is determine plausible infectious causes, advise on testing to order, and then help decide the risk benefit of empiric therapy like antibiotics, steroids, IVIG, while that testing is pending. Because a lot of the things that were mentioned take like a week to come back. So to drill down on determining plausible infectious causes, there's the history and physical, there's the initial lab and imaging results, but I wanted to talk a little bit about the exposure history. I felt bad because I think there were there was an exposure, I think a clear exposure that might have helped like make the thought process even, I think, smoother than it already was. And here's my sort of simplified approach to the exposure history in 3 buckets for people with inflammation and spinal cord dysfunction. Exposures to look out for are travel in animals, color-coded in green, sex, color-coded in red, and young children, color-coded in blue. This is my daughter. This patient, actually, before I get to that, if you color code this giant table, you can knock out almost everything on the table, like 90% of things, pretty smoothly in a few minutes in the room. And in exposures in this case, this method was reasonably helpful in determining what to send as a test. So for travel in animals, the patient actually had a mosquito pest problem in her home. She was like a homebody, like her outdoorsiest thing was walking on the Beltline, but she had a mosquito pest problem at home. She had 3 male partners for sex. And actually on the way into the hospital, she was pleading for STI testing. And she had no young children, and she works from home and had like very little other human contact in recent weeks. And so the diagnostics and risk-benefit decision-making can kind of flow from here. Arboviral testing, meningitis encephalitis panel and STI testing, and plus minus on an upper respiratory pathogen panel to get adenovirus and some enteroviruses. And this doesn't have to be everything, and it shouldn't be, but it's a nice core foundational set of things to send. All right, we're going to switch gears, talk about West Nile for a moment. What is West Nile virus? It's a flavivirus in the Japanese encephalitis virus antigenic group. It's spread by Culex mosquitoes. The amplifying reservoir is in birds, and the dead end hosts are in humans and equids. Somebody in the chat actually wrote, did this person meet a dead crow? That's a reference to if you see a lot of dead crows in your neighborhood, West Nile is very active in your neighborhood, at least historically. West Nile is active in the summer, particularly August, when this patient presented. It was introduced into the US in 1999. There was a big outbreak in New York City, and it sort of rapidly disseminated around the country. 2003 was a huge year. 2024 is sort of a medium year. And this is by state, this is by county, and this is sort of a dashboard, which is on the CDC website. CDC has wonderful dashboards in real time for lots of different seasonal and zoonoses type pathogens, and I highly recommend using it to think about your pretest probability when you're stuck on a difficult or atypical case. Clinical manifestations of West Nile. Most people are asymptomatic. About a quarter develop West Nile fever, which is a nonspecific febrile syndrome. And less than 1% develop neuroinvasive disease, which has a high mortality. Children more so than adults get an aseptic meningitis, which has a high likelihood of full recovery. Adults more than children can get encephalitis and or acute flaccid myelitis, which happens in a small proportion of patients. West Nile neuroinvasive disease, the risk factors are increasing age and immunocompromising conditions. It often leaves persistent neurocognitive and functional sequelae after months to years. It may include extrapyramidal symptoms and flaccid paralysis. If you come in with burgeoning or developed flaccid paralysis, the less weakness you have early portends a better recovery potential. Most functional recovery occurs, if at all, in the first 6 to 8 months. And the adage is a third get a lot better, a third get a little better, and a third don't get better. Other clinical findings of note include a wide range of ocular diseases, including chorioretinitis, which is really common and often asymptomatic, and a rash, which is up to 50% of the time in West Nile fever. It's a sort of non-specific viral exanthem. It's almost always on the trunk and extremities, sometimes the face. A quarter to a third have symptoms associated with it, like dysesthesia or pruritus, and it's associated with lower risks of neuroinvasive disease and death in an age-adjusted model. Here's an example, which is actually a couple of these look exactly like what the patient had. Basic lab findings from the blood, nothing is really helpful. And from the CSF, there's usually a moderate lymphocytic pleocytosis. Sometimes it's neutrophilic early in the disease and a moderate amount of protein in the CSF. Our case was pretty typical for that. Imaging findings, CT is almost invariably normal and MRI sometimes normal. Sometimes abnormal findings develop at the get-go, and sometimes it's much later on in the course. Cephalitis, classically deep gray matter signal abnormalities, and acute flaccid myelitis, classically anterior cord signal abnormalities, like in this case. Here are some examples of classic findings. The lab diagnosis with IgMs, serum and CSF. You can do convalescent testing 10 days after a negative test. If you have a high suspicion it was sent too early, do IgM again. Our case had a really high IgM in the CSF. PCR is primarily for research and blood donor screening. Otherwise, it's adjunctive in very select scenarios. Treatment supportive. There's a variety of agents without a clear benefit. Some of them might have a clear harm, and trials in this space historically fail to enroll successfully, and so the data is hard to parse. Prevention, use DEET. Or some sort of mosquito repellent, but DEET has the higher percentage means it's longer lasting. It's safe for most anyone as long as it isn't ingested or used in excessive amounts. And permethrin treated clothing is a great thing to use in high insect activities in the summer, but it's not a replacement for DEET. Take home points. The myelopathy syndrome makes a big difference to the differential. Transverse myelitis, broad, acute flaccid myelitis, narrow. For transverse myelitis, ask about travel in animals, sex, and toddlers. Diagnostics will flow from the answers, and so does the risk-benefit discussion about medical interventions. Use the CDC website to gauge the likelihood of zoonoses and seasonal illnesses. It's super helpful. Infection with West Nile is common, usually not severe enough to reach medical attention, happens in the summer months, often comes with a viral exanthem or a non-specific syndrome, but it can be totally asymptomatic. It usually is. Neuroinvasive disease is rare, but can be devastating. Diagnosis is with IgMs mostly. Treatment is supportive, and prevention is with mosquito repellent, DEET plus minus permethrin treated clothing primarily. Okay, thank you very much. I'm going to stop my share and introduce Dr. Kraft, and I look forward to any questions sort of towards the end. Dr. Kraft is an assistant professor of neurology and neurosurgery at Emory. She went to Medical College of Georgia and completed a neuro residency at Thomas Jefferson University Hospital. Following this, she completed a neurocritical care fellowship at Emory University, where she continues to practice neurocritical care. Her academic interests are in quality improvement in critical care. She is the mom to two boys, Vaughn and Christian.
Unmuting yourself is a good plan. Hi, guys. Thank you so much for inviting me. This was such an interesting case. So I'm really happy to talk with you kind of about my thoughts of how, as a neurologist, we worked through this. I worked with this case on Valerie Generet, who is the neurohospitalist who originally saw this case. So certainly a case that we enjoyed discussing. So go forward. Let me see how I get my slides to go forward here. So I'm just going to go through the presentation and how I, as a neurologist, thought about it, my differential, and then the thoughts on the top diagnoses. I think we've got a lot of great idea input. So I put a few neurologic diagnoses that I felt like probably wouldn't get as much airtime in the last talks. So her initial presentation, I think, was really interesting. So it said she was, oriented times 4, cranial nerves were intact. We look at her lower extremity weakness. Her initial presentation, it says she's 4 to 5s bilaterally, kind of weaker proximally, but it states that she's not able to walk. And generally, when I think about somebody who's unable to walk, that's somebody who's 3 out of 5 or less in their lower extremities. So to me, that was substantial, that even though she was able to kind of give this strength, clearly she was weaker than the 4 out of 5 that was stated. Importantly here, her sensation is intact. So it said print and perk is intact, but she had mildly decreased vibratory sensation like in her feet down, and her proprioception was intact. So to us, this indicates that her dorsal columns are likely intact and that this likely doesn't extend to the peripheral nerves, and her reflexes are intact, which in somebody who's coming in with progressive lower extremity weakness, that matters to us because we're wondering, is this something like AIDP or Guillain-Barré? Those are the same thing, in which case the reflexes would not be intact. But sometimes you can see that when someone initially presents. So then she became my patient on her second day of admission when her strength was progressing to worsen. So her strength became 2 to 3 out of 5 in her lower extremities. And important here was that her left was slightly stronger than her right. And so when we talk about progressive weaknesses in neurology, a lot of times especially when you're talking about something like an acute, like Guillain-Barré syndrome or other things that are going to kind of progressively extend up, or even some of the diseases that progressively extend down, those are generally symmetric in nature. And hers was not symmetric how she presented. She also had this double vision that was reported, but her cranial nerves were intact, which was really interesting and even when I saw her, when she was talking about the cranial nerve, when she was talking about her double vision, if you don't see a cranial nerve abnormality, something you can do is kind of shine a light in someone's eyes to see where exactly the light is hitting each eye. And sometimes you might see that these are slightly off center, meaning that the eyes are not aligned perfectly straight. It's just kind of a quick non-ophthalmologist way of seeing the eyes are slightly out of line, but I didn't see that in her. So her double vision, which didn't appear to be monocular, I saw one of the notes previously in the chat, was very subtle if it was there, what she was experiencing. And just of note, this did come and go. She wasn't constantly experiencing that, which was interesting. She had no weakness in her upper extremities. So this was progressing, but had not progressed to her arms yet. Sensation was still unchanged when she came to me. Reflexes were the same. The notes say 1+ at the ankles, but that's all kind of subjective, right? Neurologist, 1 to 2. And then one thing that they were checking, so anytime somebody comes in with weakness that's progressing, we want to be checking negative inspiratory force as well as vital capacities. Her vital capacities, I didn't see documented, but her negative inspiratory force was significantly decreased on this day to -28. And then they repeated it to make sure that was true, because you have to make sure somebody has a good seal around the device. And it was still -24. And each day it remained low when she was in the ICU. This makes you worried that your patient's going to have a precipitous respiratory decline, which is why she was transferred into the ICU, was to watch for this. But I will say she looked great and she was able. So another thing you can do, just kind of on a quick exam at the bedside, to look at vital capacity, which is kind of how much air you can get into your lungs, is to have someone count in one breath from 1 to 20. 20 equals about 2 liters, which is a normal vital capacity. And she could, in one breath, count to like 25. So her vital capacity was fine, at least on kind of like a bedside exam. But we were worried about like weakening of her diaphragm because of this negative inspiratory force. So she came in, so then she had the MRI, which I put here, shows these, shows this like extensive cord lesion, which you may or may not appreciate if you don't look at these every day, but this is noted on the T2 imaging, and it's bilateral. It's generally within the gray matter of the cord and involving the anterior horn cells, which is really important when I think about this case as to what this is, because there are only a few things that predominantly affect the anterior horn cells. And then of note, despite that double vision, her brain was normal, which we already talked about. So this was kind of my differential in her coming into the ICU. So transverse myelitis, which can be caused by a numerous things, which we talked about. So infectious, different inflammatory conditions, a lot of autoimmune mediated conditions from various antibodies, a paraneoplastic syndrome, acute flaccid myelitis. I mean, she is like, read the textbook of an acute flaccid myelitis, which we're going to talk about, except for her age. Then we talk about neuromyelitis optica spectrum disorder. Her age and this longitudinally extensive transverse myelitis made this higher on my list. We would check an aquaporin 4 on serum for this. MOG, which is kind of a sister to NMO, but different. And so you would check a MOG on serum. Multiple sclerosis. This is less likely given this like LETM lesion that she has, as well as her age and the rash that she presented with. And then, you know, she had oligoclonal bands on her CSF, but you can see this with any inflammation in the CSF. And so I think that's really important to know that when that's sent, unless you have a specific thing you're looking for, it may be positive just because you have inflammation in the brain. And then cord infarct, because this was an anterior lesion, this has to be on your differential, but this patient was progressing over days, very unlikely in a stroke. And on the imaging, there was no ADC correlate, but she did go back for a second MRI just to get the DWI and ADC to make sure this wasn't a stroke. So acute flaccid paralysis. Generally, this is seen in children and older people who are immune compromised, which our patient didn't really check those boxes. You see this prodromal fever. It's rapid in onset with asymmetric weakness, which is really important in her case because most of the things that I see that are this ascending weakness are not asymmetric. Usually, they don't have any sensory involvement, but you can have sensory involvement. And usually, you're going to see this anterior horn cell involvement on imaging, and you're going to see some gray matter involvement. You're going to have pleocytosis in the CSF, and generally it's viral in etiology, but we have to look for everything else, and especially because your patient's progressing, you also want to treat for the other things that it could be. We had a great talk on the viruses, so I'm really not going to go deep into this slide. But then kind of the other thing I wanted to talk about on my differential, because this is a rare thing, but I also had a case at Midtown recently that was this, and it had been missed by 2 other hospitals before she came to us, and she had a very specific syndrome. So while these are 2 different patients, I do want to talk about this. So NMO is a spectrum of disease, but the core clinical characteristics are optic neuritis, and you can present with just one of these things, and I think that's why this is important. So optic neuritis, you can have an acute myelitis, which is what our patient have. You can just have area postrema syndrome, so the sudden onset of vomiting because of where the aquaporin 4 channels are. If you have a lesion in that area, patients just come in with nausea and vomiting, an acute brainstem syndrome, and then you can have these other very specific syndromes based on where the lesions are. I'm just going to put this in here. I assume we'll send these slides out, but the important thing is that for the new 9 years ago criteria, you just have to have one of the core clinical characteristics and a positive antibody. And so in her case, she would meet, and she doesn't have NMO, which obviously we know that, but she would have acute myelitis, which is why this needs to be high on your differential, because if this isn't treated acutely, it can progress very rapidly and cause death in one patient that I had recently. So you want to have this high on your list. So for the imaging, I think the thing that's important here is this like longitudinally extensive lesion. When you think about transverse myelitis, so obviously we talked about the infectious causes of this, but when we see these longitudinally extensive lesions, we think about NMO. Usually it's in the gray matter, which our patient had across multiple levels. Why we don't think about multiple sclerosis in this is because in multiple sclerosis, it's generally a one segment lesion when it's in the spine. It'd be very unusual for this to be this extensive. Also, it's going to be affecting your white matter tracts more than your gray matter tracts. And then you see this associated cord swelling. Usually you'll have enhancement, which you'll note in this case, there was no enhancement, which is very typical of acute flaccid myelitis. But you cannot have enhancement. Up to 36% of cases that are documented don't have enhancement. So this still should be on your list. And then, so treatment, obviously our patient got treated with 5 days of high dose steroids. I think that's the most important thing to initiate acutely. And then in our patient, when she came into the ICU and did have these progressive symptoms, as we were trying to figure out what this was, we started plasma exchange, because if this was any sort of autoimmune mediated process, that would be either IVIG or plasma exchange would be the fastest thing to kind of clear out the antibodies and stop the process from happening, which was our ultimate goal because we didn't want her to progress to respiratory failure. So these are my cute little boys, and I'm happy to answer any questions. And I will stop sharing.
Thank you, Dr. Kraft, and thank you, everybody who have contributed to this CPC. Special thanks to as well Ken and Clark, who was as well co-leading this CPC. We'll open for a couple of minutes for questions. If anybody has any question to bring, you can always open the mic.
Mohammed, I don't know if you see Dr. Marshall's question in the chat. You want me to read it out loud?
Go ahead.
As a PCP, we often see a mild presentation of viral exanthem, fever, and other non-specific complaints. I will extrapolate to say, would it ever be advantageous in the outpatient setting to get a serum West Nile virus, trying to balance value-based medicine, but also to help from a population standpoint?
Can I jump in on this one?
Please.
I think it's reasonable in the right clinical context where you need a diagnosis. Like most people, like for example, actually, this was, I wasn't going to talk about this because it's sort of like in the zeitgeist, but like, why do we need to bring it up? But anyway, Tony Fauci famously this summer got West Nile fever, not neuroinvasive disease. And he was like admitted to the hospital and there was like an FUO workup. And I think that is a good opportunity. I sent it once a couple of weeks ago for like somebody who had a fever for a little too long and was like repeatedly seeking care. And like, it's starting to get like, do you have a malignancy? Do you have, autoimmune disease that we haven't diagnosed yet? I think for the typical, I have a non-specific viral syndrome that's been going on for a few days, I don't think it's particularly helpful for the patient. And from a population standpoint, they do PCR-based blood donor screening. And so they can add serologies onto blood donations whenever they're doing sort of an ecological type study. And so it's not particularly helpful for defining the likelihood that there's transmission in your neighborhood, for example.
Thank you so much, Dan. Can I ask one more follow-up question just based on some of the conversation in the chat, which was, for this patient, was serology done for West Nile virus, or was it only done on the CSF? And if it wasn't, would this have been a patient for whom you might have entertained that early on?
Serum serology wasn't done. And yes, I think in retrospect, I probably would have done it. But it was sort of, they got an LP like very, very early in hospitalization and it was like sort of already sent. And we were like, okay.
Can I ask a question though, just from like a neurologist standpoint? There are a lot of autoimmune things that we see positive in the CSF when something has like a neurologic disease, but isn't positive in the serum. I would assume though that West Nile would be positive in the serum if it's going to be positive in the CSF.
It should be, but
okay. Just a question, because I think that's,
yeah.
Can I comment on this? This is Catino. I just had West Nile virus encephalitis patient who absolutely refused the LP, and I did serology, and it was positive, and he did just fine. Just something we can, if it's in blood, it should be in CSF and vice versa. So if LP is not possible, I will substitute with serology early on if I have concerns, especially in this rash and the place we live. So that was great case. Since I have a microphone, I have a question to Dr. Kraft. Did I miss it, or is she received Plex and IVIG?
She just received Plex. So if you do Plex, it will remove IVIG. Generally, I like a lot of the data on the autoimmune condition state that they're equal. But I will say that if I have somebody who is progressing from a respiratory standpoint, I will generally always do plasma exchange because I feel it's at least amongst our group, we feel like this is the more aggressive thing to immediately remove the antibodies. So I just immediately put her on plasma exchange. And then it was when the West Nile came back, I think she had already gotten maybe 4 sessions and it was stopped because it was really started for the concern that it was an autoimmune condition while we awaited serologies.
Jackie, I think you're the first person who used Plex on West Nile. And I was wondering if it did any good or if it wasn't nothing really.
It probably, if I had to guess, just based on the fact that this is West Nile, maybe the steroids helped more than anything. The Plex wasn't done for West Nile. It was done because we didn't know what it was at the time and she was worsening. Again, it was stopped as soon as the West Nile came back. It was just started because because the NIF was worsening and we were worried that her weakness was worsening. And if this had been something like NMO, if you don't do something to stop it, it will just run rampant and could, cause her to become quadriplegic and vent dependent. So that was the thought.
Thank you.
I'd like to jump in to point out, I was actually, I was like more worried about NMO than West Nile for here. And so, yeah, so for this, and so I was sort of like, you guys sent a bunch of great testing. That sounds great. Please do steroids and Plex, and like we'll just follow up the testing later, which is the cadence of how a lot of these diseases go in encephalitis and inflammatory spinal cord lesions. And so it's also, it makes it really hard to study them because these people, a lot of them get steroids and or Plex and or IVIG, and the patient actually 2 days into Plex was like, I can move my arms again, woo! And like we were like, I don't know if that's just time or if that's the methods you're getting. And because you can't enroll this in a trial, this ends up being like the retrospective cohorts that you get and try to make sense of that data. And it is really hard to. And so, that's why treatment is supportive. We don't know.
Yeah. I see we need faster testing. I agree.
Lana, would you mind sharing how the patient did?
Yes, I was just typing it in. So she was discharged to acute rehab. Unfortunately, when I was stalking her chart, she did re-present back to the hospital, I think because she started to have significant burning of her lower extremities. And so like they wanted to work that up, but that's probably all from a neurology standpoint. I guess it's kind of how it progresses on.
Yeah, well, so I think that's actually an important healing part of this. So when we actually see patients, even with Guillain-Barré or these diseases, start to have that burning, they're so uncomfortable. It's very painful, but I do tell them this is generally a sign that they're recovering and that the nerves are starting to recover. So I would actually say that's a positive thing, despite the fact she's obviously uncomfortable and really painful. To me, that's a good thing.
Awesome. If no further questions, I guess we will end here 1 minute before the time. Thank you very much for everybody for being and contributing to the success of this CPC. We'll meet with you next time in the spring when we have the next session. Thank you very much.
Thank you.